my dear friends, actually, you should be understanding that you are going to give an exam which is not an exam which is a entry level exam. It is an exam which is they will be taking the exam thinking that you are basically a consultant. All right. Because after passing your EDIC, you are eligible to be registered with the General Medical Council. You are eligible to be registered in all of Europe. And if you know the language also, now the language is also not necessary because they are not getting the skilled people out there all over Europe, Australia, New Zealand, everywhere there is dearth of skilled personalities. So EDIC is an exam where after passing the exam, you will be a consultant. So obviously the level of the questions will be like that only. So do not think that you will be given question of the MD level. It is not like that, or MBBS level. So this thing has to be, and such international degrees are recognized all over the world. So if you can understand this, and then only, so that is the reason why I always tell you to go through the studies. If you read the studies, which are the latest studies that are coming, because they will ask you question in such a fashion which has come latest in the journals, latest in the practice that has been done in the in your circuit. For example, they will not ask you a question, what is the dose of CRRT? They will never ask you this question. They may ask you a question, but they will expect, for example, in the CBS, they can give you something else. They can ask you a question, but you have to give that answer in such a way. I'll give that answer to you. I've asked this direct question, but I'll give that answer in such a way so that they understand that you know the subject. All right. So your answers should be very specific and accordingly what we are doing today, that you have to understand. So please interact. I'm giving some examples. The exam that I took, I don't know how many of you, 4 of you actually attended my exam. And I'll ask those questions only again to you and you see exactly what you answer. And I'll tell you basically what to tell. Nothing, because in the CBS part where you are giving the pictures, you don't have much of choice to show your expertise. But at least they will ask you such a question in such a way they will understand whether you are a consultant or not. Just see, I'm trying to share let me share. Now see, very straightforward question. Elderly woman presented with breathlessness following her son's death. So what is the diagnosis? What does image B represent?
Takotsubo.
Yes, yes. You tell me? Yes. क्या बोल रहे हैं आप?
Stress cardiomyopathy. Takotsubo cardiomyopathy.
Yes. Now what does image B represent? You have 3 questions here. Anybody?
The abstraction, or I don't know.
Obviously, something has been given which is not related to medicine, isn't it? But related to the name. What is this? 2 of the candidates they answered, but the word Takotsubo, what does it mean actually? So that you have to understand. If you don't know the meaning, then that is the so it is known as basically a octopus trap. This is an octopus trap. Somebody told fish trap, all right, that can be taken into account, but octopus trap basically is the uh, is what is seen. That is the reason the Takotsubo name has been given. And Takotsubo normally involves the apex of the heart. But you should know there is a terminology called reverse Takotsubo, which also involves the base of the heart. So when you are given a Takotsubo cardiomyopathy, you should be knowing everything, because it may come as a question also in the long case. So I'll show you that. So, and the ECG changes. ECG changes, see what are the ECG changes that you can see here? Tell me.
Prominent R waves on V1, V2, V3 with ST elevation.
Yeah. So ST elevation, ST coving, isn't it?
Yes.
Oh. So you should be telling exactly. You may have also a QT prolongation sometime. All right. So these things you should remember actually the changes, ECG changes of Takotsubo cardiomyopathy. They sometimes are not very permanent. They're sometimes once it is a reversible type of disease. Slowly when it comes back, so the ECG changes also they get changed. So the ST elevation definitely is there, mainly in the leads, which if the area which is being affected. So that part you should be remembering. So Takotsubo cardiomyopathy, this was the question that was given. So but every question has a number, so you have to answer it like that. So very straightforward question. Takotsubo cardiomyopathy, here most probably the apex has been involved. It looks like a chamber, that is the octopus trap has been given. The name Takotsubo means octopus trap. It is Japanese terminology. Obviously, you find the changes that has been shown in the ECG. Now, what is this device that I asked the question? Patient was put. Now, you may not be getting this direct clue. Here, I have given a very direct clue, so you can answer this very easily. So, I have given a direct clue: the monitoring device following exploratory laparotomy. So, even if you don't understand, you know what exactly this is. I hope you can understand this. And those who gave the questions, everybody understood. Everybody gave the answer. I don't know whether they have seen this device or not. Especially in India, this was available till 2012-13. After that, this is not available. So you have to see it by the manometer from the bladder. So you can understand what is this.
AP monitoring device.
Yes.
The abdominal pressure monitoring.
Yes, abdominal pressure monitoring device. But there is a kit that is available in your place. Where if you are not from our country, from other places, you might be. This is available there. Now, you should be knowing about this because they may not be giving you this direct your clue of exploratory laparotomy. They directly may can ask you about the monitoring device. So you have to answer this. For example, this one. So they may give you a video of this like this because they're very common nowadays. And you have to say what? Tell me, patient present with acute shortage of breath, identify the condition. They may directly say this one. Give you this yes. Yes, tell me, what is this?
It seems to be a long point and barcode sign. The previously what I have seen was barcode sign.
Yeah. Did you see the? So you have to say there is. If they ask you, say the changes and then the diagnosis. So what are the changes that you are finding?
Line point.
What are the changes that you are seeing? What are the abnormalities that you can see here?
The one
in this
part is
picture,
not
what
moving.
abnormality
That
is
means
there?
it's a long point.
Here you find a lung point. In this picture,
Yes.
what I have stopped it. Where is the lung point here? Here you see the pleura. There is no lung sliding, number one. The second is there is no lung pulse. Please see first from the before. Is the lung sliding? Is this lung sliding? There is no lung sliding. See, the pleura is not sliding. Is there any pulse of the lung? That which comes with the heart pulse, is it there again? See, it is not there. Let us see again. Barcode definitely is there, but directly don't jump to the barcode. If they ask you, you have to tell every point. There is no lung sliding. There is no lung pulse. Now in the M mode, I have to say this is the M mode. We are taking, this is a stratosphere side or a barcode side. And here is the basically, see, this is the lung point. Here you find the seashore side. Here you find the barcode side. So this point is the lung point. So you have all the four findings here. So they will tell the findings that you are finding and what is your diagnosis. So directly don't jump. There's a barcode sign. So this is pneumothorax. So you don't get the full marks here. You are a consultant. You have to give everything 1, 2, 3, 4. I am telling you every time that you are giving an exam of a consultant. You are not a resident now. With this exam, you can register yourself with all the major countries in the world. So do you expect that you will be given something which will be very easy for you? They will be giving easy, but if you have studied it, it is easy. See, this is nothing difficult. No rocket science, no lung sliding, no lung pulse. Now you have to, this is the B mode, which I am seeing. Now in the M mode, this is the M mode, this line comes, this is the barcode side, and I'm waiting for the lung pulse. Yeah, lung point. Yes, this is the lung point that you have shown. The lung point. The lung point. Yes, this is the lung point. All right. So this is the way you answer. Now, what is this? Nobody could answer this. This one.
Sir, anaconda inhalational.
Yes. Now Janaki is given a right answer. This is a sedaconda. Exactly. Anaconda is or sedaconda. In sedaconda, we normally use sevoflurane. We can also use isoflurane. The first person, because all the 4 candidates who gave this exam with me, nobody could answer this because I think you have not seen this one. So if you have not seen this, see this. I think you will be given this question because this is the latest one that is there in the market. So sedaconda device, where we are basically giving sedation to our patients with the help of this with this device. We pass at a rate of 2 ml per hour of isoflurane or sevoflurane that goes to the patient, comes back and get absorbed here. Remember, this machine, this one is FDA approved, but this is only for one device can be used only for 24 hours. And you should have a monitor in your ICU which should be showing you the minimal alveolar concentration of your halogenated anesthetic. So this is a halogenated anesthetic has been used for sedation. All right. So if you are using this, it's fine. If in our country, very few centers are using this. This is from my ICU. And if you are not using it, please know that this can come as an exam in the exam. See, this is the new one. Good, Janki, you have given the answer. Are you using this one, Janki?
Sir, I've seen once, sir. It's a demo piece.
You have seen once. So you might be getting this question. There is another machine that has come in a bulk one. There's a big box type machine that has also come in the market. So you should go into the net and see that picture also if you don't know it. Because they may be asking you this question. Because this is the latest one that is there with the intensivists. Whatever new comes, they will give you. Right. So Sedaconda device. Very good. Now what is this? Only 4 of the candidates who gave, only 1% answered this. So what is my point is that you may be getting for example, you given a red color, you may be given a green color here, and you may be asked what is happening. The patient is on ventilator and on sedation. Suppose the urine, this is the urine. Suppose it comes in a green color. So what is this? And this is a red color. The patient was there, unconscious, from a car, and the patient came in the ICU. Following that, the color comes like this when the treatment starts.
Methylcobalamin.
Methemoglobinemia.
Methylene blue, if given for G6PD deficient patient, can cause lysis.
Methylene blue will change the color into green. This is red, and this problem most probably has hemoglobinemia.
If patient had G6PD.
So what has happened to the patient and what has been given and what is causing red? This is the question. The patient was inside the car, fuming. What poisoning you expect?
Carbon monoxide poison.
And what has been given? Hydroxycobalamin has been given.
Yes, for
cyanide comes red from hydroxycobalamin. Yes, you are right. Vaishnav, you are right. You told that. I have seen that. You have told methylcobalamin, right? Hydroxycobalamin. That is the reason of this color. So if it comes green, patient might be sedated with propofol that is given a green urine. So that means you should be knowing certain abnormal coloration of the urines that come in the ICU. Apart from the age-old porphyria. They're not going to give you porphyria nowadays. Hardly you find it. But they will give you this type of questions. So where from do you will get this type of questions, this type of pictures? See, in the bottom I have given you. the NEJM challenge test, image challenge. Go to the NEJM site, NEJM journal. There are thousands of images. They will not only increase your knowledge in medicine, but in intensive care, you will learn many things. Many things will come. Believe me, when we gave the course, we gave our exams, I got immensely benefited from that. So go to the image challenges. See, this exam you are giving not only to pass the exam, you have to elevate your knowledge to a level where nobody can reach. That is your aim. Your aim is to elevate your knowledge. If you think that I'm going to elevate my knowledge, you will always pass. If you are going to give the exam, then I have to pass the exam, you are not going to pass. You are learning new things. The moment more you learn, you become more knowledgeable. And that knowledge will come from more of the pictures that you are seeing, the videos that you are seeing. That will give you the knowledge. So go on every day, 50 images you go and see. Maybe they are not related to intensive care also. Go on seeing them. It will help you out. All right. So now, these are some of the examples that I've given. Now see some of the loops and graphs. They'll give some of the questions. So everybody knows this. What is this? Which mode?
APRV. Pressure release ventilation.
Yes, Varsha, we have told APRV. Janaki, you are telling something? Anything? Anybody wants to add this or basically qualify this? What is the question basically?
Which mode?
And
where is it used?
Exactly. So there are two part of the question. So what is the answer? The first answer.
It has been used widely in the management of ARDS, but it failed to prove that it's better than the other modes of the ventilation.
All right. And what is the answer of the first? What is the first answer that you gave? Which mode?
APRV.
Now, just wait. There is the problem. Why APRV? Why don't you say airway pressure release ventilation? Why don't you tell the whole thing?
Okay, airway pressure release ventilation.
Exactly. Right. Tell the whole thing. ARDS. See, everybody knows ARDS. Even I'll tell you, it is better to say acute respiratory because it is always better to spell out the full form rather than the abbreviated form. There are two advantages. One is by the time you are telling that, you are also thinking in your mind the next line you are going to tell. So airway pressure release ventilation, you tell the whole thing rather than APRV. All the examinees who have given the exam with me, they all told APRV. So that is wrong. Yes, you will get the number, but the impression that goes is wrong. So APRV is airway pressure release. We don't know. They must be needing that also, full form. So you know about this ventilation. You have a T high and a T low, a P high and a P low. And how this P high is selected. Suppose the patient is in SIMV mode or a SCVC mode. You want to transfer to APRV. How do you select this P high, this pressure? Do you know that?
So to achieve the tidal volume which was being delivered with the conventional.
Fine, but what is your P high? It's arbitrary, whatever you choose. What is the P high that you choose? Normally, how do you set it? Suppose you must not be directly starting airway pressure release ventilation mode. Will you start directly? You will not start directly. You will start with the conventional modes. And in that conventional mode, you check the plateau pressure. And when you want to shift the patient from your conventional mode to APRV mode, your plateau pressure is the P high. And your P low is 0. And it is an inverse ratio ventilation, completely inverse. If 5 minutes, 5 seconds of your inspiratory time and only a 0.5 second of respiratory time, that is 1:10 ratio. It is 10:1. 10 times inspiration, 1 time expiration. Just the opposite, what you are doing in all the modes. But more or less, you have completely reversed it. So I'm just discussing it. They may ask, the same thing can be done in a PCIRV, special control ventilation with inverse ratio ventilation. What is the difference between airway pressure release ventilation, and a PCIR. Suppose question comes here, how it differs from PCIRV. Suppose the question comes.
Will be used in spontaneous also. Spontaneous breathing.
Right, fantastic. So Anup is absolutely right. So that means here, see, these are the spontaneously the breath, the spontaneous breaths that are coming. We can see those graphs which are in the inspired in the T high mode. You see, so that is the dips that are coming, that is spontaneous respiration. So that means in PCIRV, they're not allowed to take any spontaneous respiration, whereas in airway pressure release ventilation, you're allowed to take spontaneous respiration. The patient is allowed to take, is encouraged. So this is the difference. They can ask you a question. All right. So what is this? The importance of giving this graph is that you should know every capnography. Every Go and read every capnography. I think you must be knowing this one, and you should be knowing all the other ones. You will get a capnograph. If you get a picture, be ready with any type of picture in the capnograph.
Bronchospasm. Seems to be bronchospasm.
No, this is not bronchospasm. Take your time. Anybody?
Endobronchial intubation.
Right. I'll be very happy who can say which lung you are showing the first and which was the second. This is a biphasic form, isn't it? So go and see which is the first lung, which is the second lung. All right. So the point is that you will be getting this type of questions. Endobronchial intubation, fantastic. I don't know who said this. Anup, you said, or somebody else? I missed who has said this. Good answer. But that means you have to read. My point is you have to read capnography as a whole. Partero. Capnography you have to read. You'll get any. Now you will you have to read all the waveforms. So they may give a CVP waveform. They may give a capnograph waveform. They may give you a plethysmography waveform. They can ask the plethysmography variability index. They may give this type of all the waveforms that are there. Intra-aortic balloon pump, they can give a waveform, but normally intracranial pressure, they will give a waveform. So you all the waveforms, you make a chart and go on reading those waveforms one by one, so that you don't miss a single one. So you should be knowing all the waveforms. All right. This will also improve your knowledge tremendously. Now, for example, so this is another one, a pressure volume loop, where you see a concavity in the inspiratory limb. So what is this? All my students who gave, 3 of them answered this.
Flow starvation.
So this is flow starvation. So now they will ask you what is volume starvation. How do you know? This is a flow starvation. There may be volume starvation also. So there may be peaking also of this. How over
distension? This is a bird beak sign due to hyperinflation of the lung.
I don't give you Vaishnav. What is your answer?
Bird beak sign.
Yeah, yes, that is the beak sign. Fine.
Due to hyperinflation of the lung.
Yes, the hyperinflation shows a beak sign. So I am just telling you, you can get questions, anything related to a pressure volume graph, anything related to a pressure volume, that is a pressure time graph, where you see both the flow starvation and the volume starvation. You may be shown a situation where I am telling you to go and go. Basically, my objective is to read all the graphs and loops properly. You should not miss, because this one I gave so that you can, only one person answered this. What is this? Asynchrony. Most of them answered in a different way. Only one person answered correctly. And what is the clinical consequence of this? Nobody told this.
Double trigger.
Yes?
Reverse trigger.
Yes. I can't get you, Janki. Anup, I couldn't hear you properly.
Double trigger.
Reverse trigger.
Janaki, yes, tell me.
So is it reverse trigger?
Reverse trigger.
Reverse triggering. Anybody else? All right.
It could be double triggering. Double triggering.
Double triggering.
Raji? Yes.
So ineffective
So what is the
flow,
clinical consequence?
insufficient flow.
What is
Yeah,
the
it's
consequence, clinical consequence of reverse triggering? That has also been shown in the second graph. In the volume time graph, I have shown that. See which is not being triggered and see that is being triggered. What is the difference in the volume that is coming? So the volume is increasing, isn't it? So this is the increase in tidal volume. Sudden increase in tidal volume. Reverse triggering is a very fantastic thing that was found in 2012. Actually, see, I have not seen a reverse triggering because since 2012 onwards, I am not doing my night duties. As a consultant, I come in the night, but a person who is doing a night duty, a resident basically sees this problem. When the patient is very well sedated, deeply sedated in the night, many of our residents do that. That time the diaphragm is triggered, reverse triggering. The ventilator triggers the diaphragm. It is not the patient which triggering the ventilator. It is the ventilator that is triggering, and that is reverse triggering. And that has been shown like this. Here there is an increase in tidal volume that occurs, and not much of clinical consequence, but definitely excessive dependence. The patient, it takes time for the patient to get extubated. So now most of the people they told is double triggering. So this is the confusion that occurs with double triggering and reverse triggering. This is not double triggering. Yeah. Now, what is double triggering? Double triggering is that if your inspiratory time is too small, the patient wants to be there in inspiration, but your ventilator is going in expiration. So what happens? The patient again tells the ventilator, give me something. I want something more. Why you are going to the expiration? So it triggers the ventilator again. This is double trigger. So you must be doing all the triggerings. For example, all the asynchronies that you must be knowing. For example, the trigger asynchrony. The first trigger asynchrony is, what is the first trigger asynchrony? Suppose what is your trigger level that you keep normally in your patients?
Two.
Do you select a flow trigger or a pressure trigger nowadays?
Flow trigger.
Flow trigger.
Flow trigger. How much flow do you want to keep?
2.
Up to 2.
In an adult patient, we keep how much?
Up to 2.
2 liters. Now I keep the 2 liters. I don't want to keep it 5 because if I keep 5 liters per minute, the patient has to generate 5 liters like this to trigger the ventilator. That is very difficult for the patient. So I keep 2 liters. So now suddenly somebody says, why to keep 2 liters? Let us keep 0.5 liter. Let us keep it a bit less. The patient will generate it more, will trigger the ventilator like anything. Well, yes. Even if the ventilator circuit, if it moves, the ventilator gets triggered. Any splash, any cardiac oscillations, the ventilator gets triggered. So that is the reason if we keep the trigger time too low, trigger value too low, it will be auto triggering. Now, if I keep the trigger time too high, 5, then what will happen? The patient's breath will not be understood by the ventilator. It will be wasted. So it's a wasted breath. So these are the first 2 triggering. I know you all know this. I'm just revising. Also for myself, Then comes the cycling. So now what is happening here? The second this time is the inspiratory timing. So what is happening? The limit that you have selected, the trigger limit and cycle. In this way we go on. So you have selected inspiratory limit of around suppose 0.8 seconds. and the patient wants to be there you've kept it much lesser than that, 0.6 seconds inspiration. Normally, we do not keep like that. So this too short is inspiratory time. So the patient again tries to trigger the ventilator, double triggering. Now, after that, a senior resident comes, well, it's too short a inspiratory time. Let us increase it. He makes it 2 seconds. Now the patient wants to go into expiration. The ventilator is still there in inspiration. No, I don't want to go. So what will happen? In the pressure time graph, at the end, you will get a hump. So they can give a hump at the end of the pressure time graph, ask what is happening. So you have to tell this is a too long inspiratory time. Too short inspiratory time, double triggering. And the third one is the most important one, is the pressure support expiratory sensitivity. In somebody say expiratory sensitivity, somebody say inspiratory termination. What is that? When the flow comes down to certain percentage, the ventilator goes to expiration. Now, in a COPD patient, the patient wants to be in expiration for a longer period of time. So I have to keep this expiratory sensitivity or the inspiratory termination at a higher level, the 50%. That means once the flow comes down to 50%, it goes into expiration. Now, somebody doesn't know it, he keeps it 20%. The patients want to go into expiration, the ventilation is still in inspiration. So what will happen? The sternocleidomastoids will start working. The patients will be very much restless. You don't understand, and you say that the patient. So this is another type of asynchrony that occurs. So you should read the asynchronies. I gave the last one, the reverse triggering, as because so that you should know all the asynchronies properly. Definitely you are going to get one question from an asynchrony. So know what is this? Which phenomenon and what is the problem? It's a very simple question. There are two parts of the question. What is the phenomenon called? The left side phenomenon. And what is the problem for which this phenomenon is being termed as?
Auto peeping. Auto peep and
Dynamic hyper.
See, when you are giving the exam, you have two questions. Answer each question. Do not jump into the other part. You are telling what is the problem that you have answered, half of it. What is the phenomenon known as?
Waterfall phenomenon.
Yes?
Waterfall phenomenon.
Right. Anup is right. It is waterfall phenomenon. So if you don't know waterfall phenomenon, go and read this. Point is, the interesting point is, when we are basically getting an intrinsic peep, suppose 10, I am measuring it by giving an expiratory hold, and I can measure it on directly. Certain ventilators, you have to good ventilators you just give a sensitive, tell that start to measure inspiratory peep, intrinsic peep, it automatically give a expiratory hold and it will be measured. Now the vector of the auto peep is from down up, from there is the alveoli towards the bronchus, whereas peep is coming from up down, that is from above bronchus towards the alveoli. So both the vectors are opposing each other. So that is the reason we give a peep to counteract auto peep. But how much peep? So that is being explained by the waterfall phenomenon. See, in the first picture, as if the water is falling, this blue line is falling so deep. But if I give a peep of 6, suppose the auto peep of 8, so the waterfall basically becomes shallow. It is being countered. Now, if I give a auto peep more than peep, what will happen? It will become all the same. So the waterfall has come shallow. Now it is going up again. So I don't want to hyperinflate again my alveoli. So that is the concept that you should know. Waterfall phenomenon, dynamic hyperinflation. You know it very good, Anu. I think others also know it. And you should know about this. Now see the laboratory parameter and give this answer properly to me, this first question. Definitely this is going to come, this type of questions. See, I got similar question in my EDIC like this one. Tell me, what is this? A simple one. You are getting it every day in
It
your
was supposed
in your ICUs. Basically, the question is, what is the disorder? It
it
is a
was
single
supposed
disorder, it is a double disorder, triple disorder, that you have to answer. All right. They want the type of disorder, is it triple disorder or not? That means you should know the calculation, you should be calculating in your mind. See, the albumin level has not been given. So forget about the albumin correction.
It's
Albumin level
ketoacidosis.
is not, it doesn't mean that, yes?
Diabetic ketoacidosis, most probably.
No, it is a diabetic. It is not the. I am telling the ABG disorder that is there. It is diabetic ketoacidosis. It's fine. Urine ketone positive ketoacidosis may be there. What is the ABG disorder you are getting? It's a metabolic acidosis. What type of metabolic acidosis? Is there a associated respiratory acidosis or not? It is there, fine. Or if there is associated respiratory alkalosis there or not, or there is associated metabolic alkalosis there or not. So
So
whether there are
both
two, three
metabolic,
disorders are there or not, that is basically the question.
so
high
high
anion
anion gap
metabolic
metabolic acidosis along with
with
respiratory acidosis and metabolic alkalosis.
Fantastic. So this answer, if you give this answer, you get the full marks. All right. So you have to calculate this in your mind and very quickly. So that means you should have your formulas fitted here. Fatafat calculate, you should calculate and you should answer the question. Because you don't have much of time, 1 or 2 minutes to answer the questions. So you should be knowing that, and you will get this type of, definitely you are going, they'll give it a ABG, ethylene glycol poisoning. You just check after the exam whether you get this or not. Either ethylene glycol poisoning you will get, or you will get high anion gap metabolic acidosis. They can give you a normal anion gap metabolic acidosis till enumerate causes. They can they can give you a triple disorder, is very common. They can ask you a triple disorder, is very common in diabetic ketoacidosis. So that is the reason the urinic ketones they have given positive, just a hint. They're giving you a hint. Go through the ABG properly. You might be getting a triple disorder here. So that is the point. Every question is very important, where you find that exactly what is written there. You have to see, and if you add on to this about something, the PO2 is given. If the FiO2, if you are giving a FiO2 and a PO2, both of them are given, then you have to definitely tell about the PF ratio. Do not miss that. They have not given you the albumin here. If they have to give you the albumin, that means you have to go for the albumin correction. Definitely there is some problem. Do you understand? Whatever they are giving, every point is very important. You have to check into that. They're giving you this hint. Severe abdominal pain, vomiting, fever, urine ketone positive. You know this is diabetic ketoacidosis. They're not asking you diabetic ketoacidosis. They are asking you what is the disorder that you get in this ABG. All right. So you will get this type of questions. Now this is a very straightforward question. Very easy question. You will get much difficult question than this, but this is a very straightforward question. I thought I should give some easy questions also. This is one of them.
Pulmonary embolism with D-shaped LV and dilated heart.
Now the question is, they will not give you such an easy question. They will tell you, they will not give you this picture. They will not give you this picture. They will tell you a patient is being ventilated and suddenly there is a fall in the saturation and there is tachycardia, there is a fall in the heart rate. They'll give you a picture of the ventilatory settings and they'll simply give the peak pressure is 27, plateau pressure is 22. Now they will tell you what are the other investigations you are going to do and what you want to exclude here. So whenever you are getting a peak pressure and a plateau pressure normal in a ventilated patient, because in pulmonary embolism in a ventilated patient, it is very difficult to see. The only hint that your ventilator gives is that your peak and plateau pressures are normal, and you will get the saturation is falling, the blood pressure is falling, the tachycardia is happening. You are basically completely confused. That time you have to do 2 or 3 things. What are those? We'll come to when we come to the long case. So they might be giving like this, in this way. So you have to go for your D dimers. You You have to check you have to do a compression ultrasound to see whether the veins are correct or not, they're compressing or not, and obviously you have to go for a. This is a short parasternal short axis view showing a D-shaped ventricle. So you will get this type of questions, not so easy, but I've given this one an easy one. Now, what is this? Read this properly and do not jump into an answer. Let's see this. What is this? Because those who gave the answer in the exam, they told the first thing correct, but see what is the most probable diagnosis. The patient has a visual loss, pain in the back, asymmetrical weakness of the lower limbs. The sample is of CSF. What is the CSF condition and what is the most probable diagnosis? What is the CSF condition? This is easy. Anybody? Anybody wants to try? Even if you try wrongly, there is no problem. Here you can do many things wrongs. Yes?
Xanthochromia.
Xanthochromia. Is the CSF condition, you are right. Xanthochromia. And then? What is the most probable diagnosis?
Sir, even if we do delayed lumbar puncture more than 12 hours after intracranial hemorrhage also.
Your answer is intracranial hemorrhage, subarachnoid hemorrhage.
Subarachnoid hemorrhage.
You tell me, will you get pain in the back in subarachnoid hemorrhage?
No, no.
Then, this is the problem. This is our problem.
TB.
I am not reading the question. There is written pain in the back. Subarachnoid hemorrhage is called pain in the back.
No.
It still may cause asymmetrical weakness in the baby. There is a visual. Where from the pain in the back is coming?
TB.
They are basically befooling you here, bluffing you. You are a consultant. You are not a resident, Janki. Now, you just can't say that xanthochromia only occurs in subarachnoid hemorrhage. That is the problem everybody does. Xanthochromia, there are other situations also where xanthochromia occurs. They're asking that.
Tuberculosis?
Yes, maybe tuberculosis. We don't know. Maybe tuberculosis. But this is the situation. It's not a case. Xanthochromia typically occurs in certain other conditions, like one of them is very common. It's the Freund syndrome. Go and read today Freund syndrome. There is CSF hypercoagulability. There may be a tumor or there is a stenosis in the spinal canal, which is causing that pain that is coming from the back. It is some problem in the spine, not in the head. That's what they want to say. So you should be knowing why I've given this question. You should be knowing again the differential diagnosis that comes with subarachnoid hemorrhage. Because subarachnoid hemorrhage is a very common question that will come in headache. What they will give, they gave me, I got a question, I got a picture of subarachnoid hemorrhage. I saw the picture. They told me what is the condition and tell me what has happened to this patient. What intervention has happened to this patient. There was a bar hole there, which I was nearly missing. Subarachnoid hemorrhage was there, but there was a bar hole. So it was a post-op case of subarachnoid hemorrhage. That should be the answer. You understand how they are basically trying to see your expertise, whether you can see that picture properly or not. So they will give a question of subarachnoid hemorrhage. Please read it very carefully. Do not miss that bar hole in the skull. They will give you. And many of us miss it and we fail.
Could you please tell the name of disease again?
Freund's, that is Freund's syndrome, F-R-O-I-N'(S), Freund's syndrome. Go and read this today. All right. So now, you have a community acquired pneumonia. This is an easy question given. Easy question. Maybe why I have given this question, they can give you this type of wrong interpretations by the laboratory, and they can test whether you know exactly which this is sputum culture of a MRSA. All right, this is a methicillin resistant Staphylococcus aureus. So, what wrong has been given here? So they can give you a picture, wrong diagnostic picture from a laboratory coming. So I give you the answer here. You see, you should be knowing that carbapenems are inherently resistant to MRSA. So if you get a sensitivity of imipenem, it's completely wrong. More or less, the erythromycin is resistant most of the time. The clindamycin cannot be sensitive; it will also be resistant. Leave it that part. One of the examinees, they gave that answer. He is also right. He will get a number there. But here, what is that I want to ask is that you want to see if a patient comes to you and if this MRSA is there diagnosed, you are still continuing with your meropenem or imipenems or your carbapenems or not. So basically, you have to step down on your antibiotic. This is antibiotic stewardship. So this is a question on antibiotic stewardship that might be coming like this. So though I gave this. Now, what is this electrolyte abnormality?
Sorry, UVs are present hypokalemia.
Right. So very easy question. Hypokalemia, very straightforward question. So that means you should be knowing all the ECGs that will be coming. Will you please measure the QT level here, QT segment? What is the QT segment here? Please measure. Let me also measure. I always feel that they should not give such easy questions. So what they can give actually, they can unknowingly will get a case of hypokalemia. They might prolong the QT, you know.
So this is short QT.
This is a short QT. All right. Huh? So they also measure the QT, what I am telling you. I got the question at S1 QT3T syndrome. They gave, I was quite baffled. What the ECG they have given to me. Suddenly struck my mind, this is S1 QT3T. So they normally give this type of questions. So you'll get an ECG question. I got S1 QT3T. I thought I should share it with you. I got ethylene glycol poisoning in my ABG. I got that subarachnoid hemorrhage with a bar hole. So this type of questions come. Very interesting. Very interesting. I think you will enjoy the exam. Give the exam with full enjoyment, you know. Do not get tensed. If you give it with enjoyment, you will definitely going to crack the exam. So that you should remember. So with this, I can ask you, let me continue some. What is this?
Secretions.
Right. Very good. So I have many pictures like this, but it will take long time if I go on discussing them. If I find. So what is this? Can you see this one? What is this? I have already discussed. I discussed just. I discussed reverse triggering. So what is this? This is double triggering, you know. This is the double triggering. And how to reverse this situation?
By increasing the flow.
Right. By increasing the excrete speed. Very good. So, yes, right. So you will get, maybe they give you, let me see some good questions also. If you get this one, tell me the wrong things that has been done here.
I ratio be one to. It should be prolonged anyhow. I mean, if it's ventilated, it's ventilated failure.
You are happy with a tidal volume of 600 ml in a COPD patient?
No. It's not.
60 kgs weight?
Yes, it should be around 400.
So you go on checking from number 1, all right. and go on. And because when you are giving, my point of contention is that when you get the question, do not directly jump to the third point. First of all, starts every point is important. So tidal volume 600, you are not right, isn't it? You differing. IE ratio 5, respiratory rate 16, all right. IE ratio 1 is to 1.5. You want a longer expiration time or a shorter one?
Longer.
Longer.
For
Fine.
POPD, I
Then,
want 1 to 3 or 4.
right. Next.
And expiratory sensitivity should be increased to 50 in COPD.
Right. Fantastic. But before that?
Trigger should be low.
High and flow trigger is low, high.
Very high. So what will happen in this patient? There will be wasted
Air.
breath. And you
It
are
was
also happy with a huge pressure support of 25?
No.
Because this will cause, if you use such a huge pressure support, again the patient will develop autopy, isn't it? So high tidal volume, high pressure support, low expiratory time, everything is going to develop autopy. So they might give you a picture of an autopeep and tell, do the changes to reverse this situation. They have to decrease the tidal volume, to increase the expiratory time, to decrease the pressure support. And obviously, these two are also wrong. The flow trigger is wrong. I'll go to a lot of wasted breaths. The expiratory sensitivity has to be increased to 50%. So this is basically the question. You are right. Most of you are right. But answer them in a sequence. So that will give you an answer. So they may give you this type of, that I asked you already, patient's urine, what is this? So you get a green colored urine, you know that this is nothing but propofol, isn't it? Induced. So what is this lesion? Yes, tell me, Varshav.
It was given methylene blue, I think.
You can get that also, yes, no problem. But propofol is a more correct answer because it is green urine, all right. What is this?
This looks like space occupying lesion.
Where is the lesion?
There is this pontine myelin.
Yes, whenever you get something in the pons, and that too in the ICU, there is nothing else than central pontine myelinosis. All is this, but you don't answer central pontine. You can tell that also. You can say this is basically I see there is some myelinating problems in the demyelination in the pons. They'll ask you why this is for. They may be asking another question, maybe due to very overcorrection of sodium very quickly. All right. So they may give you this. I'm not going to. This is very easy. This is very easy one.
Degree AV block.
See the T waves? But if you see properly, if though this question has been given, but sometimes the questions also a bit ambiguous. Here, if you see the T waves, in V6 you see the T wave. In lead 2 you see the T wave. They're not so enlarged. They're not bigger. They're not going beyond the R waves. Yes, this is hyperkalemia. Only in V1 and V2 I can find that the T waves are larger, that is bigger than the R waves. So basically, there are two most important things. T waves should be symmetrical, T waves should be peaked, and it should be more than that of the size of the R waves. So if you see that in V6 it is not there, but still, if you get this type of question, maybe some ambiguous question you might get. So this is basically hyperkalemia, you are right. So there are so many questions like that. We can continue on and on and on. It is not possible, obviously, for you also, for myself also, to continue with the CBS. My main question is that CBS is very easy to pass. Very easy to pass. Concentrate on the question very well. Read it very well. If you don't read it well, it becomes problematic. Now, why I am telling this? I'll give you an example of a case where you will find why I am telling this. All right. Let me share my other slides. Just give me 2 minutes. Are you finding this interesting or as if I am only speaking? Because the teacher also is eager to know whether I am doing a good job for you or not.
That's really very interesting.
It's interesting?
Yes.
Thank you so much. Because you can always criticize me. You know, criticism always makes a man perfect. So you can always criticize if you want, but let us see. I am just trying to tell my experience to you, and let me show you then this one. Now, answer, read this question very carefully. I'm telling you, because this is very important. So I am starting with this, your short case scenario. All right. So read this very carefully. Do not again jump into conclusion. I am reading this for you. All right. A 66-year-old car mechanic suffered from fever and cough for 5 days. All right. Let me give you the next one. Sorry. This one, let me give first. All right. 72-year-old female presented with a sudden chest pain, heaviness radiating to the hands, and shortness of breath. She is a known hypertensive, controlled on ACE inhibitors. She had a personal loss a day before when her son died in an accident. On examination, she was anxious, morose, dejected. Every point is important. Over and above her pain. Respiratory is 27 per minute. Pulse rate 98, blood pressure 160, 98, cardiac sounds are there, no adventitious sounds, clear lung, no peripheral edema. Do not jump into your diagnosis. First of all, see. Investigations, TROP I is 50, BNP is 180, ECG, ST elevation in V6, echo, ejection fraction 70%, mild apical wall motion abnormality with widening, angiography refilled 45% block in the LCA, chest CT within normal limits, patient's troponin I rose over 2 days and then gradually reached the normal limits. Have you understood the scenario? Patient with sudden onset of chest pain, heaviness radiated to the hands after a personal loss, raised troponin, raised BNP, V6 is raised, ejection fraction around 70%, 45% block of the LCA, nothing else.
This is, can we comment?
This is?
It could be, again, we discussed before, stress cardiomyopathy or coronary vasospasm.
Do not jump. Wait.
Or coronary vasospasm.
What is the broad diagnosis?
Diagnosis.
Question that has been given. What is the broad diagnosis? What are the salient diagnostic points? What are the causes leading to this condition? What might be the causes that lead to this condition? And what may be the cause of such condition in this case? That is the second question. So what you answered is?
Stress cardiomyopathy. And
that is the answer of question number 2. What may be the cause of such a condition in this case?
Stress.
That is stress cardiomyopathy. But what is the broad diagnosis? So if you don't know the broad diagnosis, you have missed your case. And as a consultant,
syndrome.
Yes.
Acute coronary syndrome, yes.
Acute coronary syndrome, who told that?
Yes.
Okay. So Anup, you are telling it is acute coronary syndrome?
Yes, chest pain and ECG change.
Do you think that you will be given such an easy question in reading? Acute coronary syndrome, directly they will give you? They may give you. They may give you.
No.
They may give you. But obviously, I am not giving this here. Just to acute coronary syndrome, I am not giving you. This is acute coronary syndrome, right? But you have to classify that what type.
Coronary vasospasm.
All right, maybe coronary vasospasm. I am not. You have to give the right answer. You will give it if you know it. See, it is again. See the question properly. You see the question. What is the angiography revealing?
Only 45%.
This less than 50% block. All right,
yes.
This is another hint I am giving you. Angiography showing less than 50% block. But the troponin is raised, BNP is raised, maybe the patient is a bit in failure, ST elevation is there. So it is a case of coronary syndrome itself, right? You are right. It is a myocardial infarction.
Non-occlusive myocardial infarction.
Yes?
Non-occlusive myocardial infarction.
Right. What is that known as?
Minoc.
Minoca. Myocardial infection with non-occlusive coronary arteries. This is the answer. They were given a case of Minoca. That is a very common in the ICU, no? You hardly will be discussed, but you will get a case. See, this is non-occlusive because only 45% block in the LC. This is not an occlusive coronary artery disease. This is Minoca. Why I am giving you this question? Because you might be getting this type of very, very interesting type of cases. They might come. And you might miss it. You will definitely see. You are not wrong, Vashirov, when you told that this is a case of stress cardiomyopathy. Yes, it is a case of stress cardiomyopathy. But it is one of the conditions which cause this. There are other conditions. What is the commonest cause of Minoca? What are the salient diagnostic points? Chest pain, right? There is no problem. But the most important point is all the signs of myocardial infarction with a blockage in the coronary artery less than 50%. That is the bottom line. You'll get many cases in the ICUs. Now, what are the conditions leading to this? What are the causes of this, Minoca? This is a broad question they have asked. What are the causes of this? What are the causes? The first cause is the plaque rupture. Plaque rupture. The coronary cause is the plaque rupture. The second cardiac cause, obviously, number one is stress cardiomyopathy, Akoshubo. The second is maybe the heart stunning due to all of you get atrial fibrillation with sudden ventricular, very fast ventricular rate, a PSVT. They might cause Minoca. Third is you may get a pulmonary embolism from where Minoca may occur. Non-cardiac causes, commonest AKI, sepsis, hypoxemia. They also may cause Minoca. So my elevation, always ST elevation doesn't mean that it is, and obviously the vasospasm that you are saying, it may cause Minoca. Many a time we are using lot of non-adrenaline, and that non-adrenaline might be causing coronary vasospasm that causes Minoca. So Minoca is a situation which is a very specific to ICU. So you are giving a question which is related to intensive care. It will not be a case of acute coronary syndrome like very in black and white. You will not get that. They are giving some amount of hint which is different from that acute coronary artery. Isn't it interesting? What do you think? Anup, tell something. Interesting or not?
Yes, sir. Yes, sir.
So
Yes.
how do you confirm your? So you might get a question like this. Let me see. One moment. If I get a picture of Minoca for you. Where is that? Yeah. So you have plaque rupture, unstable angina, myocarditis may cause stroke, AKI, sepsis, pulmonary embolism, and the diagnosis is less than 50%. That is very important. Most common cause is plaque rupture, not TS cardiomyopathy. Plaque rupture is one of the problems. And troponin I VNP will be raised, you will get ST elevation. Remember here that normally the treatment is treatment of the cause. And obviously, you'll be asked these questions also. I'll come to all this for you. So, see, when you are looking, a question has been given, how do you differentiate from MICARD, myocardial infarction with coronary artery disease? So, if you see the questions one by one, and so with the coronary artery disease, the main difference is obviously the block is more than 50%. And treatment here is mainly treatment of the situation. And it has been seen from certain, there is not much of prospective trials on this very peculiar condition, because most of the time they are being done in the very sickest of the sick patients. We have to continue the basic treatment. Along with it, we give two things has been found. One is the AC inhibitors are very protective. The second is the statins are very good. And third, the double the antiplatelet therapies, they have been used. They are more or less equivocal. And prognosis is not good. Prognosis is equivalent to that of a myocardial infarction with coronary artery disease. And it is worse than that of the general population. Prognosis is not good. So, the major adverse cardiac events like stroke, like arrhythmias, like sudden cardiac arrest, like remyocardial infarction, heart failure, they all occur in the next 5 years. So we have to be very vigilant in this type of cases. You have to follow up these cases very carefully. That is the reason why they are asking this. What is the major adverse cardiac events in this condition? Do you want to follow up your case after it goes, or it's a very good thing that it's a very good prognosis? This is not a problem. No, prognosis is not good. We have to follow up these cases carefully after the patient goes get discharged from the ICU. That is the reason they have been asked this question. So that is the reason I gave you this a bit atypical type of question, atypical type of your question this time. There are many other very interesting cases, but we can't discuss all of them. If I get another chance, definitely I'll discuss. Now, if I get is a very straightforward question. All right. Now see the question. You read this one. Anybody you can read so that I am telling for the last 1 hour, 1.5, already 1 hour, 15 minutes.
66-year-old car mechanic suffered from fever and cough for 5 days. He ignored initially, but when the respiratory distress increased, he came to casualty. He had undergone knee replacement 20 days before. He complained of pain in his right leg. His saturation deteriorated to 70% on zero point 0.5 FiO2, GCS 11/15, MAP 55 mmHg, BP being 70 by 40, pulse rate is 120 per minute, occasional PSVT, respiratory rate 38 per minute, CVS S1 S2 present, chest bilateral crepitations. His right leg was edematous. His patient was taken in ICU. Patient intubated and put on mechanical ventilation. Cultures taken, ABG done, antibiotics and low molecular weight heparin started as per ICU protocol. Fluid resuscitation given. Vasopressor started and investigation sent. ABG pH 7.36, PaO2 56, PCO2 30.
Yes.
BNP 468, D dimer 3600, drop by 0.1.
Then
Compression ultrasound is positive. TAPC is more than 11, it's 12 mm, and FACRV 30%. PASP by LV systolic volume 1.2 mm per ml. Patient was on ACVC mode with PP 27, P-plat 22, static compliance 25.
what do you think?
Pulmonary
Straightforward question.
embolism
Straightforward,
seems
isn't
like
it?
right leg
This is
has.
I have not given any clue. There is no no twist in this one. Very straightforward one. But they have given you certain values which, as a consultant, you should know. So obviously, a 66-year-old car mechanic going for a knee replacement and coming with this type of situation. What exactly is this one? What is your diagnosis? A clear-cut diagnosis. Tell me.
EDIC,
This is a
pulmonary
case of
embolism.
yes.
Pulmonary
This is
thromboembolism, right leg DVT.
right. Pulmonary thromboembolism, and I find this is a pulmonary thromboembolism. Now see the ACVC mode. Why I have mentioned this? You have a peak pressure of 27, plateau pressure of 22, isn't it? That means the peak and the plateau pressure are more or less not changed, isn't it? But why they are giving you when you are reading this question, you try thinking why they are giving me this TAPSE of 12, FACRV, fractional area contraction of the right ventricle of 30%. What is PASV by LVSV? Why they are giving me? They must be driving me into certain situation,
Patient has got
isn't
the
it?
right ventricular dysfunction also.
Your RV function is RV strength.
Yeah, right. So that means what is my bone of contention is that you should be knowing the normal values of TAPSE. You should be knowing the normal. They will see that your answer will make them understand whether you know the pulmonary artery systolic pressure divided by the left ventricle stroke volume. Why it is 1.2 they have given? Does it have any, what is the reason of giving this? Because it is having some prognostic outcome for them. If it is more than 1, it is associated with decreased right ventricular function and it is potentially adverse outcome. That is basically they are mentioning here. Right ventricular shortening less than 35% is not very good sign. TAPSE normally is around 15 to 17, below 12, that means the right ventricular function is very bad. So they basically are telling you, so this is not a good case. And your BNP is raised, the troponin I is not very much raised. But still, troponin I and BNP both are prognostic indicators for pulmonary embolism. So the point is you don't have to miss anything in pulmonary embolism. You just can't miss it. That is the point. I'm not going to the questions. I'm telling you this. They might be giving you very straightforward, what is your diagnosis? How do you predict about this patient? So here the prediction when it comes to a pulmonary embolism, you should be knowing that the prediction scores that are there. Isn't it? For example, I come to that. For example, this one. So you should be know the revised criteria. It should be there in your mind. See what is your what is the heart rate, whether there is a surgery in the last 1 month or not, whether the patient is having unilateral lower pain and there's edema in the pain. Yes, it is there. Age is more than 65. So see the score. So that means you should be knowing the score. They want you. They have given everything here in this case so that you can make out the score. 66. Normally the score is 65. So they're telling you that edema. I think they have given this question. The pain and edema is there, isn't it? Yes. Pain in the right leg. Yes, see? It's complete because they're giving this to make out the score. Mean arterial pressure 55. So they want you to calculate the score here in your mind. At least you should be knowing this. And you should be knowing the clinical probability. What is the clinical probability from this score? So the high critical probability of pulmonary embolism, the score is going beyond 5 in the simplified version or in the original version. Any one version you should at least remember. And they'll go for a severity index. And you see the severity index score. You all know the PACE score. The 4 persons who gave the exam, everybody told me the PACE score, the simplified PACE score. Fantastic. You should be knowing this score. And you might be, it's not always possible to calculate it, but something should be there in your mind to tell, yes, from the PACE score, I believe that this score is going beyond this. So this is very important here. So how do you know the severity of the condition that you know? Now they will ask you very easy questions. Enumerate the changes in the ECG, the test X-ray, the echo, the ABG, the CTP. I think you all know this. I told you I got a S1 QT33, but the commonest finding is sinus tachycardia. Isn't it? So what is this? Then I will show you one thing. You might get a video of this one. Your pulmonary embolism. If somebody is showing you a pulmonary embolism with this video, if you don't answer this, you should be knowing the condition, the sign known as.
McConnell sign.
Yeah. See again, this is the McConnell sign, all right. So see this video well, you might be getting this. I don't know why they're very much fond of this video. But normally we don't, at least I have not seen much. One or two cases I've seen. This you should be knowing. All right. This you should be knowing. They must be asking you about this echocardiography of the patient, and you should be knowing about the TAPSE score, the FAC 35. This things is very important. Sorry, the tricuspid. I'm sorry. It has been wrongly printed out there. So this is basically the diagnosis by the bedside, where somebody told me that I'll get severe acidosis here. Do you get acidosis in ABG? So this basic mistake you can't do. All right. So normally you get a respiratory alkalosis with the PCO2 less than 36, increase their PaO2. So these things, this wrong at the chest X-ray, the commonest chest X-ray is normally normal, but you will get an oligemia. Oligemia is very common. If you don't know also the West Marcus sign, you don't have to mention any sign. The oligemic chest X-ray, there is no problem. That is a better answer, I tell you, rather than telling a West Marcus sign, because you are a consultant. You don't have to tell all the signs. All right. Yes, there is free wall kinesia, but the apex is paired, commonly known as McConnell sign. This is the answer that we give. The quality of the answer, the way you speak is also very important. All right. So now, so I'm not, because we are already around 1.5 hours. So pulmonary embolism, you should not miss anything. You should go for it. And now this one. 26-year-old car mechanic suffered from fever, cough. Very straightforward. You will get these straightforward questions. Don't worry. There'll not be a twist all the times. But he ignored. This is a very straightforward question. You know what is the most difficult question when you used to give MBBS exam? You are told the difficult most case is which one? Do you know? When you get a case, whether if you get a hydrocele or a hernia, that is the difficult most case to pass. Because if you miss a single thing there, you are failed. So this is the easiest case that you get in the ICU. And if you miss a single thing, you are failed. Though you will get numbers, you will not miss it, but you cannot say wrong here anything. See, what is the case you just see? A 26-year-old car mechanic suffered from fever, cough, ignored initially, respiratory distress, and came to the casualty. Saturation deteriorated, mean arterial pressure deteriorated, respiratory rate high, patient taken in the ICU, intubated, mechanical ventilation, cultures taken, ABG done, antibiotics started, fluid resuscitation given, vasopressor started. You get higher iron gap, metabolic acidosis, potassium is 7. When they are giving you potassium 7 and creatinine increase to 2.8, what question do you expect?
RRT.
Yes. So they will move to RRT. All right. So you must be knowing everything about RRT. If I have taken your class on RRT or if you've listened to any of my lectures, then you can go to the YouTube and listen to the lectures of RRT on my, or I know if you have attended any of my classes or lectures, then you will know that RRT is such a vast subject where you have to discuss it. I don't know how many of you have attended it. So now the question comes here, my dear, what is the diagnosis? You can't miss anything here.
Community
See the
acquired
diagnosis.
pneumonia with septic shock with
Yes, pneumonia with septic
acute
shock.
kidney injury, stage 2.
With pneumonia, right?
Pneum-
It is a community
Pneumonia,
acquired or hospital acquired pneumonia.
community acquired.
Community acquired pneumonia.
So see, you missed that point. You cannot miss. Community acquired pneumonia with
Community acquired pneumonia with septic shock with acute kidney injury,
right.
stage 2.
Yes. All right. All right. All right. This is any, this is all right. Or you can say community acquired pneumonia. ARDS patient is the patient is in all ARDS also.
Yes, sir. ARDS PF ratios 150.
Again, when you go to the definition of ARDS,
Yes,
have
this is
everything been explained
moderate,
here?
Acute was
moderate severity,
sudden
moderate
worsening.
severity are this because PO2 FiO2
Why?
ratio is between 100 and 200 according to
Now,
Berlin definition.
fine. Acutely onset from pneumonia, we have a hypoxemia which is moderately hypoxic. But has they given
Radiological
you the
diagnosis.
X-ray? Have they told you about the PEEP? Have they told you anything about to show that exactly the definition of ARDS fits? Either the Burley definition or the Kigali definition. Do you know both the definitions?
Start from
Either
7
chest X-ray,
days.
ultrasound, or CT. One of them needs to show.
Where are they? Before telling ARDS, shouldn't I get all the definitions fitting into the ARDS? It's my question to you. I'm not telling that you are wrong. But you just tell me, are the definition of the ARDS fully given here? So when you are telling ARDS, keep in your mind whether I'm completely fulfilling the diagnosis of ARDS and which definition you are taking. So you have to tell by this definition this fits into the ARDS. Just a PO to FR ratio of 150 doesn't mean the patient is in FR ARDS unless otherwise every criteria of ARDS is fulfilled. Isn't it? I feel like this. I don't know, maybe you are correct. It doesn't mean that always I am correct. So yes, you are right. Community acquired pneumonia with septic shock. If I would have been a examining item, I would have told multiple organ dysfunction syndrome. They would have asked me, what are the dysfunctions that you are getting? If they have a chance, they don't have a chance now. They go on asking you a question. You will not miss an answer there. You will not miss a point there if you tell multiple organ dysfunction syndrome. All right. So you take cultures. You should not be knowing about ventilation, antibiotics. What fluids you give?
Conservative fluid management.
Which fluids? You basically have to resuscitative fluid or maintenance fluid.
So since this is a case of sepsis, we can attempt to give the initial resuscitation, 1 to 2 liters of crystalloids, since the patient is already in renal failure and has got minimal urine output. Further, we need to assess with dynamic parameters.
Okay. Go on telling, please.
So using dynamic parameters, we can further continue the maintenance fluids if required, and if the patient's MAP is not achieved, we need to start vasopressor as soon as possible to maintain the MAP mean arterial pressure more than 65. And because this is a case of septic shock, after taking cultures within an hour of diagnosis, within an hour of patient's diagnosis, we should start antibiotics. And since patient is intubated, we can send a endotracheal tube culture as well as blood culture.
There is a surviving sepsis campaign to
I am sorry,
2020.
I missed your which fluids you are giving? Yes, you tell me, please.
So crystalloid, it can be normal saline or balance. I mean, in this case, normal saline because potassium is on the higher.
All right. So by surviving sepsis campaign, we give normally what they
30
have
ml
told.
per
They have to
kg.
give basically salad
Initially
salt
30
solution,
ml per
isn't it?
kg, but since
Usually we
30 ml
start
per
with
kg
10,
of
10 to 20
yes,
ml per kg. If it doesn't help, we will go to vasopressor. We will start with noradrenaline, then we will add vasopressin. If it doesn't work, then we will go to steroids.
fine. So when we start, first of all, the fluids. So according to you, we'll give you a normal. So the SSC campaign says that you have to go for. They're saying that you're suggesting. They're suggesting. It's a very low quality evidence. This because they are suggesting on basis of basically two papers. One is the SMART trial, and another is the SALT-ED trial. They have not taken into consideration the basics trial, the plus trial, which came afterwards, and which are suggesting that both normal saline and your this balanced salt solution have no difference in mortality. But yes, in certain situations, you have to individualize your case and you have to select. You are right, Janki, there is no problem in that. And we have to start vasopressors. Which vasopressors we start with? We start with noradrenaline. We go up to 0.5 microgram per
0.5.
kg per minute. We don't exceed that. We start vasopressin. Suppose in the night you do not have a central line. So can you go
We can
from a
start
peripheral line?
noradrenaline from a peripheral line and try to achieve central venous access as soon as possible. Maintaining the perfusion, tissue perfusion is most important.
Hello, you peripheral line from a central line within what time?
Sir, we can start from the peripheral line. We need not wait for a central line to start the infusion, but we need to try and achieve central venous access as soon as possible.
What is that as soonest? What is the time limit?
Within an hour. With,
What is the time limit?
within 1 hour of
Within 1 hour? Anybody wants to say anything? Within 1 hour? All right.
4 hours.
Yeah, 4 to 6 hours.
Right? 4 hours. All right. So yes, within a maximum time limit of 4 hours, uh, we try to get it. And the next is, yes, I go for a second drug and a second vasopressin. I go for it for 0.3 unit. We cannot miss all these things. What I'm telling you, we cannot miss these basic things that are coming up. And when we start steroid, how many hours we start steroid?
Sir, 4 hours of starting. I mean,
Yes. So non-adrenaline, I cross it, I start after 4 hours. The point comes here, there's a Spanish trial on steroids. So normally we are keeping the patient on hydrocortisone. Why hydrocortisone? If they ask you why hydrocortisone, because hydrocortisone is having some amount of mineralocorticoid activity and it matches the internal milieu of your steroids. That is the reason hydrocortisone. But in a pure ARDS case, many a times dexamethasone has been used. And the Spanish trial, one of the trials came in 2019, it has shown dexamethasone to be excellently used and is better than others. Why they've used dexamethasone? These are 4 reasons for that. Dexamethasone is the longest acting one of the steroid. You can give it a single dose. Third is dexamethasone does not have any mineralocorticoid activity. Many a times we need a dry lung, we don't need that mineralocorticoid activity. And fourth is that after 10 days, up to 10 days, dexamethasone can anytime be abruptly withdrawn. So it is contrary to that of the hydrocortisone. These are the 4 very important points for which dexamethasone sometimes has been preferred. If they ask you a question, you should be knowing about dexamethasone also. That is why I am discussing this. Now, when they come to the next question, that when do you add inotropes?
When we can't get MAP more than 65 by IV fluids, then we will proceed to emetic.
despite dual vasopressors, if we are not able to achieve the MAP and the cardiac contractility is poor.
Tell me one thing.
Persistent lactic
You tell
acidosis
me
or
one thing,
SpO2 less than
Varsha.
60.
Yes. Yes. What are you telling us, Raj?
Persistent lactic acidosis or SvO2 less than 60 or
All
with the
right.
echo.
Anybody else? Anything else? Go on. Try. Do not write in the chat box. It is very difficult to answer. You see your chat box and go on answering. See, it is not possible. Please speak out. This is a very interesting thing, very important, because you told that if the mean arterial pressure is not achieved, I'll start inotrop. Which inotrop you will use? Suppose mean
No,
arterial pressure has not been achieved.
we will
Sir,
start
adrenaline,
noradrenaline.
Adrian.
You use
adrenaline
adrenaline
is,
as an inotrop.
Vasopressin.
sir, if the depending
You
on
use vasopressin as an inotrop.
no, no, no.
Noradrenaline is preferred.
Adrenaline is preferred.
Noradrenaline.
Noradrenaline is preferred.
The
Noradrenaline is
patient
an
is
inotrop
already
or
on
is a
noradrenaline.
vasopressor? Which
Noradrenaline
is
is
an
a vasopressor.
inotrop you want to give, which is
Dopamine,
called cardiac contractility mainly.
No,
Non-adrenaline
dopamine,
no
vasopressin will
peripheral,
dopamine.
cause peripheral vasoconstriction.
no peripheral vasospasm.
So which
Sir,
one you want? Inotrop.
Dobutamine.
Noradrenaline.
adrenaline.
Dobutamine.
Sir,
Right,
dopamine.
dobutamine.
Dopamine causes vasodilation.
Dobutamine. Do you know any other inotrop? Name
Milrinone.
levosimendan,
Levosimendan.
dobutamine. So what is a dobutamine? It is an inotrop or it's an inodilator?
So,
Inodilator.
Later.
Inodilator. If it dilates in the peripheries, will the mean arterial pressure fall or it will go up?
Fall.
Then why are you telling that the mean arterial pressure has not been achieved? I'll start inotrop. You tell me. You yourself are telling that with the inotrop, when inodilator, my peripheries will be dilated, my mean arterial pressure will fall because mean arterial pressure is diastolic pressure plus one-third pulse pressure. So my mean arterial pressure will fall. I'll use inotrop.
So cardiac contractility.
Yes, cardiac, I have not achieved. What do you say? There is a global hypoperfusion. The perfusion is not right. So the cardiac index is below 2.1. Normally the cardiac is not achieved. That is the time I start inotrop. So how do you know? You may not be having an echo with you. You may not be having a pico with you. So how do you know that there is a hypoperfusion? Yes, you are right. Lactate level are rising. It is one of the signs. But from a simple ABG, can you tell? ABG and a VBG, can you tell that is a hypoperfusion? Yes.
SVO2.
Right. If the SCVO2 is not, it is not reaching 70%, number one. Number two,
mixed venous saturation.
anything on the CO2, PCO2 level?
PCO2 gap more than 6. But
Right.
for that,
I see, I
SCVO2
do a arterial, I do a ABG, I do a VBG. I see the difference between the CO2. If the CO2 level is very rising, very much high, more than 6, 7, 8, it's going, there is hypoperfusion, signs of hypoperfusion. So either you see the cardiac index or you see a difference in the CO2 level. If you have a good hematocrit around 30% and your SCVO2 is going down below 70%, and you have already achieved your mean arterial pressure, but still these things are there. That is the time you add your inotrop. So important. When do you start your inotrop? There is no dilly-dallying in it. Very, very, very clear. And you cannot miss this one. Dobutamine is the choice. Levosimendan is not at all a choice nowadays. It's no advantage on dobutamine. It's only costly, nothing else. So I'll use dobutamine. All right. So they will ask you, you don't have anything? Do you have dopamine? When do you use dopamine? Dopamine was extensively used in 2008. After the soap investigators, Daniel D. Baker came out with a study that dopamine is bad, non-adrenaline is good. It causes dopamine causes mortality is high, arrhythmias are high, everything. Dopamine went down. Now, number one, to more or less now it is out of the scenario. But there is one condition where dopamine is used. What is the situation?
Arrhythmias.
Right. So hypotension with bradycardia. You are right. So hypotension with bradycardia. Maybe if I have dopamine, I might be using dopamine. I'm not going to the of this. So tell me, how do you differentiate to rule out here to pre-renal versus renal failure? How do you differentiate? You must be knowing this. This is very easy.
Pina and Fiuria.
Right. But they will not ask you this question now. I tell you, I've given this, they will not ask you this question. They will ask you, go and read today the different phenotypes and subphenotypes of sepsis-associated AKI. They'll go to the phenotypes, the subphenotypes, and the endotypes. This is the latest one that is going on. Somehow they will ask this question. I don't know how they will frame the question, but they will frame a question on this. If they are asking you on pre-renal and renal, this is a very age-old type of definition that is still there, that is still continued. But the latest one that is there is this one. It is becoming very popular. And naturally, when something's become popular, that is asked in the question. So please read that. Go today, read the phenotypes, subphenotypes, and the endotypes. I don't have time to discuss that. About the role of biomarkers, they'll definitely ask you a question. So which biomarker will you use to check AKI? What are the biomarkers that you use?
TIMP, NGAL,
PCT and CRP.
and cystatin.
What did you say, Janki?
So
Procalcitonin.
TIMP, NGAL, and cystatin.
TIMP what? No, this is not the way. When I answer, if I answer or if I write something, I write. So I will go for certain biomarkers. You should know which is a damage biomarker, which is a stress-induced biomarker, which is a biomarker which is showing a effect of the glomerulus. So you should be knowing. But If I am saying that I am going for the only one biomarker, if you ask me nowadays, so there are different biomarkers that has been used. Creatinine, urine output are the basic biomarkers that we are using. Blood urea
And gal.
nitrogen are the biomarkers that is being using. But now we are using
And gal.
neutrophil, gelatin associated lipocaine, LGAL, cystatin C, yes, LFABP. And what you are telling is tissue inhibitory metalloprotein 2 multiplied by insulin like growth factor binding protein 7, TIMP2, multiplied by IGF-BP7. The value is seen in the urine. And if
Yes.
the value is more than zero point 0.3, your patient will move towards severe AKI. And this biomarker is a stress biomarker. That is, even if the kidney function is normal, if the kidney is stressed, this level goes up. So that is the latest biomarker that is used in nowadays in your ICU circuits. So you'll be asked this question about TIMP2, IGFBP7, multiplication factor inside the urine, and the value should be more than zero point 0.3. And they have divided it to zero point 0.3 to 0.3 to 2, more than 2. They have a classification also of this. Mainly seen in cardiac surgeries, they have validated this, but it is now been extensively used in many of the ICUs to see whether the patient will move towards severe AKI or not. And that is seen, and as it is a stress-induced marker, when the kidney cells are stressed, it goes into the S stage. There it is G1, G2, and S. There it is basically secreted. And that is the reason it's one of the best biomarkers. Two caveats for this. It is basically in high proteinuria, it is not very sensitive. And number two, in high bilirubinemia, it is not sensitive. It is not tested in children and below 18 years of age. So these are the three caveats of this biomarker. All right. So now the bedside assessment of renal function, they will ask you. How do you assess the patient? That whether in the bedside, when you are taking the rounds, how do you assess? Tell me one test that assesses bedside assessment. One test, anybody? Yes. So bedside assessment is seen with the help of furosemide stress test. All right. We see the furosemide stress test. Go and read the furosemide stress test. Very important. And go and read it. Now the RRT, you have to read extensively the RRT. RRT has now become a bread and butter for every ICU. I'm not going to the details of this. Indications of RRT, which modality you specify here, which suppose CBV HDF or CBVH, CBVD, when to start an RRT, read all the studies. You have 5 studies you have to read. Alien study, Akiki trial, Akiki 2 trial, Ideal ICU trial, Start AKI trial, read all these trials. What is the dose? The basic dose is 20 to 25 ml per kg per hour of effluent volume. Effluent volume, but this dose varies as to disease process, according to the disease process of the patient. But the basic dose is this. Whether to use anticoagulants, read about regional citrate, read about heparin, when to use regional citrate, what are the contraindications of regional citrate, read those things, when to stop, when the urine output comes more than 400 ml, more or less we go to other modalities like SLED, sustained low efficiency daily dialysis, or we go to a dialysis, normal dialytic process. And nutrition, remember, I do not decrease the protein levels in the nutrition up to 1.7 milligram per kg, gram per kg per day when you are giving the patient who are on hypercatabolic state, you're doing CRRT. This syndrome is known as depletion syndrome, where not only proteins but also zinc, vitamin, selenium, everything is taken out. And about the antibiotic, we do not compromise on the loading dose. Sometimes the dose has to be increased because most of the antibiotics is removed by the CRRT because they are very big. Because when you are doing, especially when you're doing ultrafiltration, you're taking out these antibiotics. They will be ask you what is the normal creatinine clearance that normally is achieved during CRRT. It is more or less equivalent to your dose. For example, if you have a 30 you are giving 25 milligram 25 ml per kg per hour of effluent dose, your creatinine clearance is around 25 ml per minute. This is I'm telling you for your own practice when you go on practicing. You should be remembering what is your effluent dose. That is basically your creatine clearance in minutes, more or less. More or less, it is like that. So you have to read all these things. This is the easiest case that you get, but you cannot miss a single question here because because this is the bread and butter of every intensive care patients, of every intensivists. So I think
Sir,
I'm
will
talking for the
they,
last 2 hours. So I am also getting dehydrated. It's not possible to speak so much. So uh,
sir,
if
just
you have
one
any
question.
questions,
Sir, will they
uh,
ask about hypernatremia, hyponatremia correction, or hypercalcemia correction, or
yes, in
potassium?
CRRT, na?
Yes, sir.
Yes,
Uh,
yes, they will ask. They will ask. But I don't have time. If you ask these EDIC people to give another class to me, I can show you basically the CRRT hyponatremia hypernatremia protocol that normally we follow. So I can tell you that. But now it is difficult for me to show you
Sir,
because
another thing
it
I
will
want
take
to
at least
ask.
half an hour time about the troubleshooting of CRRT.
Sir, also in case of toxins or metformin, toxins or
Yes, yes,
rhabdomyolysis, the
yes. CRRT has so many indications, so many indications. But
no,
they
will
will
they
be
ask
asking
the
the indications here. That is according to this case. All right. When
no
you're asking,
alterations
yes,
for the prescription? Will they ask like what change will they make?
yes, because that is the variability in prescription. You do one thing if you really want to know, you go to the YouTube. Will give my lectures on prescriptions. Maybe it's a bit old in that the variability is not shown, but in EDIC, this I have given this lecture here also in FURS Academy. You can take it from there. That the latest one has been given. Or if you really want to know another time about CRRT before your exams, if the first people ask me, definitely I can give you a detailed discussion on CRRT.
Okay, sir.
But
Thank you.
again, Janaki, it's difficult for me to
Yes, sir.
tell it now everything.
Yes,
If
sir.
if you are really interested, you request them. I'll
Okay.
definitely take a case.
Okay.
Definitely take one class on that.
Okay, sir. Thank you.
All right then. So I think I'll stop here because you are also it's a lot of time you have given to this, and I hope that you will be benefited with this. And I best of luck to all of you. I'm sure that everybody will come out with flying colors. And obviously, this is an exam. Again, remember, this is an exam of a consultant level exam, not a resident level exam. So behave as consultants and give the exam with full spirit, and you will pass. Don't worry.
Thank you. Thank you.
Thank you then. Okay. Thank you. Thank you. Bye
Thank
bye.
you, sir.
Thank you, dear. Thank you. Thank you. Okay.